Okay, now we're recording. So as I was mentioned, the test often will ask to differentiate between depression, delirium, and other conditions, right? So delirium is one that's fast, super fast. You know, one that say that can be hours, it can be days, but that is considered fast compared to dementia, right? So delirium, dementia, and depression, they often gets confused and mixed up. So delirium is a syndrome. It's not a disease in itself. It's caused by a short term, so it's the fastest one. A short term change, acute onset, causing a short term change in cognition, memory, speech, right? Example, confusion or difficulty focusing after surgery. Often after surgery, we see delirium, and delirium is highly associated with UTI in older adults, right? In fact, every time I see someone with delirium, I ask for a urine sample, right? So key factors here, it's acute, okay? It's rapid development and often within hours or days, right? So the patient comes in a hospital, is doing well. 2, 3 days later, you are asked to evaluate this patient due to delirium. So altered mental status is the key here. Deterioration, agitation, or lethargy can also happen, right? Inattention, difficulties in focus, maintaining doing the task is the hallmark. Consciousness or cognitive fluctuation is the hallmark throughout the day. Okay, so prognosis is really poor for the long-term outcome. Okay, with as much as 40% mortality rate for delirium patients within 1 year. That is huge, right? Super high. And this is something that I always look at. I look at it and I go, really? Is that high? Right? But that's the literature that states that. So you need to know this. Okay, you need to know this. What tool do you use to assess delirium? ICU. I mean, CAM. I always say the CAM ICU is the one that I use when I was an ICU nurse. So I always use CAM ICU. But for all of us here, the CAM tool, which is a confusion assessment method instrument, right, is a tool to identify the patients with delirium. So diagnostic test, what we want? We want a CNP, a complete blood count, a thyroid function test, UA, UA. And obviously, we want a drug screen just to make sure, chest x-ray, often infection disease related tests, HIV, just to make sure also because confusion and HIV patients with low CDC volume value can be confused as well. Okay. All right. How would we treat them? Okay. So this one is a bit harsh, but sometimes if they are confused for delirium, right, and they are super agitated, haloperidol or haldol is preferred. Okay. We can also do a atypical antipsychotic in alternative to haldol, anxiolytic agent aiding in sleep and insomnia, but we do not want to give them a benzos. right? Because it would potentially cause falls. Okay, so the preferred medication is a haloperidol or a atypical antipsychotic, not benzos. Okay, pharmacological management. We want to ensure the safety and measure. We also want to address basic needs like food and hygiene, maintain routine with the familiar face, clocks, calendar, things like make sure that the patient feels safe and know where he or she is in the hospital. Now, when they say haloperidol or a atypical antipsychotic, we're already at the end of the spectrum, right? What we want to do before that is provide safety, a familiar face, non-pharmacological methods like open the curtains during the days, leaving the lights on, or shut the lights off during the night to prevent delirium, right? To prevent the patient from even, if it's the beginning of delirium, we want to support the non-pharmacological methods. If we can't and the patient becomes super agitated, then haloperidol would be a medication of choice or another atypical antipsychotics. Now, it is unlikely that they would give you a choice of a atypical antipsychotic and a haloperidol as the answer, right? But haloperidol is used a lot in practice. Go ahead, please, if you have a question. You have to unmute yourself.
I'm so sorry.
It's okay.
My question is, why is the prognosis rate so poor with delirium?
Yeah, that's actually a very good question. I think it's because neurologically, if someone does decompensate uh, in the hospital, right? Usually
Yeah.
they are older patients. I'm not entirely sure the specifically reasons. I will search it up and then look it up. I just saw that in the book. That's super high.
Mhm.
Maybe, yeah, I'm not entirely sure the reason behind it. Go ahead if someone raise your hand, please. Pam.
Hi, Dr. Lopez. So I
Hey,
was wondering, what type of second generation antipsychotic would you use for that, just in case,
yeah,
instead of Haldol, for example? Is there an
yeah,
alternative? Yeah.
yeah. So anyone could answer that question? Anybody else has insight on that?
I would
What
do
else?
I would
What
do
would you do?
Zal,
Zal?
Zaprazone,
Zyprexa,
Alipiprazole, and
Okay.
Lorazepam.
Latuda, maybe.
Latuda is a good one.
Tuda?
Uh,
Okay.
what else you said that? Chris?
Zyprexa,
Zyprexa is an excellent one, better even than Latuda. Why would you use Zyprexa?
side effects
Okay,
is less.
less side effects. Okay, but also we want to do an injection, right? If possible, right? Because if someone is confused, agitated, do you think they're going to take a pill, right? So in short, really, any medication that you can do that is because all atypical antipsychotics are sedating, right? So we want to choose one which you can give uh, IM, okay?
Mhm. Okay. All right.
So
Thank you.
what, absolutely.
Mhm.
So that's a
Mhm.
great question that leads to another question that is high yield. What are the atypical antipsychotics that are IM injection?
Abi-
Invega,
Invega, Abilify.
Abilify,
Abilify.
Perfect. Guys, write that down. Write that down. Write that down because you will see that in your test. I promise you. Right? Why would you see that on your test? because it's high yield. You need to know the ones that you can use IM. Okay.
So it's those two, Invega and Abilify anymore?
Yes, we have more.
Yeah.
Anybody can call another one?
Geodon.
Geodon. Perfect.
Yeah, don't. Okay.
Okay. So what is about Geodon that makes it one of my best, I would say, like one of the preferred antipsychotics? What can you do with what is specific, not specific to Geodon, because also specific to Latuda. Latuda and Geodon, there is something specific about them. What would that be?
Less weight gain.
Take
Yes.
them with food.
Okay, we got. Yeah, we know that I call them the skinny meds, right? Abilify, Latuda, Geodon. These are preferred for me. However, there is something about Latuda and Geodon that I think was Chris just mentioned. What is it, Chris?
Take them with food.
Take them with food, right?
Yep.
One is 350, another one is 500 calories, but it's not that specific. The most important is take them with food, okay? Geodon and Latuda. Obviously, we're talking about ingestion, pills, right? Okay, great discussion, guys. Let's go ahead and get back to the topic here. Haloperidol for patients that are agitated, right? Patients that are agitated, we give them haloperidol. Also, know the delirium and getting a UA and also a urine analysis, right? A UA urine analysis, but also if becomes a thing, a drug test, right? So kindly mute yourself so we have less echo, please. Let's move on here. Okay, so how would you remember those things, right? I call it the DART. Delirium features would be delirium itself. A for acute onset. That is the highlight that we'll need to know to differentiate between others that are coming up. The A for altered mental status, and the T for trouble focusing, right? So frequent tested points, delirium is the hallmark. The hallmark is fluctuation in consciousness and cognition. Uh, Mortality rate is high within 1 year. Haloperidol is the preferred medication for agitating delirium and delirium versus dementia. Now we get into the point where you will get lots of questions from here. Okay, so when you look at delirium, it's fast. Okay, it's quick, and I mean hours after arriving to the hospital, the patient come in. My name is John. Everything is okay. I'm 75 years old, here for surgery. And then 2-3 days later, specifically after the surgery, well, it could happen before the surgery, but it usually is after a procedure. And then the patient gets agitated and you get called in. And then most likely, don't call delirium right away, right? It could be an infection. It could be something else. You get all your labs, everything it's okay. You check, and then you could call it now delirium, right? Patient agitated, give haloperidol. So delirium in itself is fast, hour to days, maybe a week, okay? Could be that long, depending if the patient stays in the hospital that long. It has a defined started point when it started. We can tell when the day, or even by the hour sometimes. It is temporary, and reversible. We can reverse delirium. Causes difficulty in attention. Cognition is the hallmark, right? It causes slow, slurred speech, and during the episode, right? Now, if we look at delirium, put it to one side. Now let's look at dementia. It begins gradually and progresses over a year. Has no certain time title. We can just say, hey, yeah, I started last week. We don't know that. The family doesn't know because it's so slow that we can't tell exactly even the month when they started. We can say, yeah, I started the 2022, but we can't really say when it started for sure, right? It's permanent. It has a worsened uh, over time. So we have medication for dementia, but they will not reverse. It's temporary. Okay. Most of the dementia. There is one that's not, but most of them in general are. Which one is not, by the way? There is a type of dementia that is related to medication. I mean, a vitamin that is reversible.
Parkinsonism?
No, not Parkinsonism.
Vitamin B12.
Vitamin B12, right? So that being said, when you have someone with a dementia, you want to check your vitamin B12, right? So we'll cover more about this one in a little bit, but that one is reversible. All we gotta do is give vitamin B12. So it causes speech problems, memory, difficulty with thoughts, remembering things, all the good stuff that you know about dementia. So don't get confused. Dementia versus depression versus delirium or even delusion. Okay, so there was delirium. The next training is 12. If you guys are new today and you haven't seen this, we do micro training, so that way you are able to get to whatever you do in life and come back to the next small training. So we have 12 small training on module 2. We're about to share the last one. Okay. Now, on this one, we'll talk about a very important subject and probably the most complicated one for this module, which are the types of dementia, right? So, as we mentioned, dementia does not have a defined type. Dementia is a group of disorders, right? Under that, we have Alzheimer's, tons of disorders that we'll cover today, right? It's a gradual cognitive decline. That's the hallmark. Very, very gradual. It really impacts various mental status functions like memory problems, solving, and organization. So main main thing is cognitive deficit, right? So impairing the executive function, the frontal lobe, right? Impair the global intellect, impair the problem solving, organization skills, and altered memory. So types of dementia, right? So you will get questions on this. This is important and kind of difficult to really group them, right? So to do that, we want to call them cortical and subcortical. So the cortical is the top, subcortical is under, right? So the cortical dementia affects language and memory. Cortical dementia affects language and memory. So I want you to think cortical and write it down, language and memories. So when we say language, we can also say aphasia, for example. That's a type of language, right? Problem. And when we say memory, we can say amnesia as well. So if you hear in the phrase aphasia and amnesia, most likely this is a cortical dementia, type of dementia, the group, right? Or the cortical. So cortical, aphasia, and amnesia, language and memory. Now um, the subcortical is associated with depression and uh, motor symptoms. Subcortical associated with depression and motor symptoms, right? So examples of that would be Huntington disease, Parkinson's disease, and HIV. Now, the cortical, three examples of that would be Alzheimer's, Pick's disease. Pick's disease is the same thing as frontal temporal disease, frontal temporal dementia, or some people even may call it frontal dementia, right? And Creutzfeldt-Jakob disease. Okay, so cortical, language, and memory. And now you want to write it down. Three examples of cortical dementia: Alzheimer's, Pick's disease, and Creutzfeldt-Jakob disease. Okay, so you want to memorize that. That's why I said that this was kind of hard. Lots of memorization. Now, subcortical under the cortical. Two associated words would be motor and depression. And the three that we want to put under the subcortical is the Huntington disease, Parkinson's disease, and HIV dementia. I said disease, but dementia, right? The symptoms would be more of dystonia, so motor, right? Increased muscle tone, right? Other key points is depression-like symptoms, so sadness and so forth, okay? So let's take a look on some of the cortical, right? We said cortical, we put three under the cortical, right? We said Alzheimer's, Pick's, and Creutzfeldt-Jakob disease. So now let's take a look on the, let's take a look on the Alzheimer's, often called that, right? So it's a cortical. So what are the problems that we see in cortical? Memory and language. So if you say cortical Alzheimer's, it is the most common type of all dementia. It's so common that some people would call it dementia itself, right? Or associate Alzheimer's as the only dementia case, which is not true, but it's a lot of the dementia falls under Alzheimer's. So gradual onset, no focal neurological deficit, and there's an acetylcholine deficiency and diffuse cerebral atrophy. So the problem here is acetylcholine that's low. Okay. So let's take a look. Next one, frontotemporal or Pick's disease. So if it's frontal, what kind of symptoms would you expect, right? Is a frontal. So frontal, it's a cortical dementia or Pick's disease. Is more typical in men. Its early stage symptoms would see personality. That's why I was trying to cue you in for frontals, personality, behavior, and language change. So frontal, lots of personality change, right? You have somebody that may be very well mannered, quiet. Now that person becomes talkative more than most, and would say things that are most likely not polite. Okay, so cognitive changes at later stage, you may see this Clover Bruce syndrome, which is super rare. I have never seen that, but it's super interesting at the same time. So this syndrome is extremely rare and is a brain disorder that can cause memory loss and behavior problems. So just check it out on YouTube. There is a case of a doctor son that had this, and no one could figure out what it was until he really figured out this was a Clover Bussy syndrome. You know, they sleep a lot. They will sleep like for hours and hours, sometimes days, and then wake up super hungry and go back to sleep. It's pretty fascinating. So Creutzfeldt-Jakob, it falls under the cortical, is another one. The cortical deformation. So this one is also called prion. So makes it a little bit more difficult for us to remember. So we had frontotemporal. Now we have Creutzfeldt-Jakob, which is called a prion disorder. It's a fatal. In this one, it's kind of rapid, right? All dimensions are slow, but this one, it really is rapid. So you get the flu-like symptoms that progress to aphasia. Remember, language and memory, aphasia, depression, psychosis, death within 6 months, right? So it is a transmitted by the blood and fluids, bodily fluids, right? It belongs to a group of human and animal disease known as a prion disorder. What else this is commonly called? There is another name for this. Anybody knows?
Mad cause disease.
Yep, mad cow's disease, right? So there was a issue, I believe, in Europe uh, that people were avoiding cows, right? Mad cow's disease. So, all right. Thank you for sharing. Uh, Now we have the third one. No, now we have the subcortical, I'm sorry, the subcortical HIV dimension, right? So HIV dimension, every time you get an HIV or HIV-like patients or a drug, there is a lot of questions on drug users. You want to check for HIV. If they use a syringe or injection for drug usage, you always want to check HIV, possible HIV, okay? So, and if you suspect it is HIV or you know the HIV, now you do not want to give any, uh, you do not want to give any medications for dementia. At this point, you want to give it antiviral load. I have seen questions where it pictures everything as a dementia case and give you all the dementia cases, all the dementia medications, and one of the answer is check for viral load or give an antiviral medication. I think give an antiviral medication, right? So that's what you want to do because giving any of the dementia medications will not help. Okay, so CDC is lower than 200, then you have a problem here. You really want the CDC to be high as possible, right? What happened when the CD4 is low? Is lower than 200? What is the risk?
Affection.
Infection, right? It becomes very open for infection, right? At that point, it becomes, like if your CD4 is low, very low, and you are in a hospital, the hospital is not the most clean place, right? So you're very open for infection. Any flu could kill the patient at that point, right? There is a potential of. So early signs, cognitive decline, um, motor abnormalities, lack of coordination, tremors, dystonia, ataxia, behavior abnormalities. So late symptoms that can even go to mutism, seizures, and hallucinations. Okay. What's important here is to know this is a subcortical. Know that if it's an HIV case, get your CD4. Do not give any seizures. Uh, give any other medication other than antiviral load. That's what they need. And kind of know the symptoms of the HIV dementia. Okay. All right. So Lewy body. Lewy body, I usually say I'm seeing things, right? Why would I say something like that? Well, because the hallmark of Lewy body is hallucinations. The hallmark of Lewy body is seeing things, hallucination. If that is the hallmark of Lewy body, would you give a antipsychotic for this patient? Yes or no?
No.
No.
Okay. Do not give a antipsychotic to a patient with Lewy bodies. Do not give antipsychotics to a patient with Lewy body because it will worsen the problem. I would be comfortable in saying all patients with hallucinations, other than drug usage, right? You could possibly give a antipsychotic, not with Lewy body. That's a task question. That's very classic. Okay. Do not give antipsychotic with Lewy body. Write that down. It's important. So Lewy body, usually I say I'm seeing things. So you remember this is hallucination is the hallmark. But it also comes with bradykinesia, right? Tremors and the Parkinson features. So another one is vascular dementia. It doesn't really fall in between cortical, subcortical. It's like on its own. Now the vascular dementia is the second most common types of a cognitive change at the later stage. Cardiovascular involvement, as you can tell. Now, just because you have a question that is high blood pressure, it doesn't mean specifically it's going to be vascular dementia, right? But most of the time, vascular dementia and high blood pressure comes together. The hallmark is carotid roots, fundoscope abnormalities, and enlarged cardiac chambers. Okay. Huntington's disease, does it fall under cortical or subcortical? Anyone?
Subcortical.
Cortical?
Subcortical.
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 Okay, subcortical, right? So subcortical, we said, what are the two words that we said the subcortical?
Movement.
Motor and depression.
Irritability. Depression.
Yep.
Mhm.
Depression and movement disorders, right? So Huntington, because it falls under the subcortical, it is a motor abnormalities, right?
Yeah.
So polypterosis movements, so movements that doesn't have any kind of shape. It's weird, like. So high incidence of depression and psychosis. Okay.
Okay.
All what I would like you to do is to do like cortical and subcortical and give 3 examples of each and remember the magic words. So that way it could guide you getting the right answer. Okay. Go ahead, please unmute yourself.
Can you go back to Huntington's real quick?
Sure, I can.
Thank you.
Oh, I'm so sorry. Here you go.
Thanks. I have it.
Okay.
Thanks.
Alrighty. So, guys, this is all in our PDF. Okay. So you don't have to. If you don't know where the PDF is located, it is under the first video of each module. Now we have a special dimension, right? This one is very special because it's reversible. Remember, all dimensions are irreversible, right? That would be a lie, but mostly correct. A small lie, I would say, right? Because vitamin B12 is a reversible dimension. Thank you all. All right. Vitamin B12. So that's why I say I get a dementia patient. First thing I do, get a vitamin B12, right? But it's rare. It's a rare, but potentially reversible condition. So all I want you to do is remember that it is a dementia called vitamin B12 deficiency. And if you get a patient that demented, go ahead, get your B12 just in case. Okay? All right. So a few things to memorize. You can say A for Alzheimer's, starts with an A. S for subcortical dimensions. And then that will be like your modem dimensions, right? Frontal dimension is also called Pick's disease for personality change. HIV is a virus, so V for the virus has a sub in the middle for subcortical dimension. A few things to help you put in place. But if you have a better one, share. Can share today, but you can also share in our forum so that others can see and learn from it. Okay? Frequent mistakes confusing cortical with subcortical or mixing up dimension types and symptoms, or even mixing up depression. You will get a question between depression and dementia because the symptoms are alike. The difference is that depression, you almost can tell when they started. It started last month or last year, X, Y, Z. If they want to answer, they can tell you at least the month, but they wouldn't tell you the reason why, right? With dementia, they'll just make it up and run away with it, right? They'll be like, yeah, I started last year, but really, they don't know. We'll go more in detail of those in a bit. Okay, so the treatment, right? Remember, they will not cure dementia itself, but it'll help slow down or at least stabilize in some ways. So dementia treatment, what we want to do first, non-pharmacological interventions, right? Is the first line agents, atypical haloperidol and atypical antipsychotics for agitation. Avoid benzos. Do you give a dementia patient benzos? No. Okay. High risk for falls and delirium. cause them to have delirium. So even with those with delirium, we don't want to give benzos. I can almost for certain say that benzos would be one of your question answers as a distraction, right? Because it's like, oh, the patient is agitated. Go ahead, give benzos. No, no, no. You know, the patient has dementia. Go ahead and give benzos. No, you know, it's a wrong choice. Okay. Now, FDA approved medications pretty much in three categories, right? You have your cholinesterase inhibitors, you have your glutamate regulators, and you have the combination of the both above cholinesterase inhibitors plus a glutamate regulator. So they're kind of easy to memorize. So if you say the cholinesterase inhibitors, right? Um, then a donazil or Aricept is probably the most common one. I'm gonna move it on to this. You don't have to memorize all the names, but if you want to memorize Aricept and Razadine and Exelon, you can. Remember, for the test, you do not need to memorize the brand and the genetic name. Memorize just one because they will always give you both together. Okay? Now, class, cholinesterase inhibitors, glutamate regulators, or cholinesterase inhibitors plus glutamate regulators. So a mixture of both. May I please have someone read and answer this question?
Which of the following is not a type of cortical dementia? A. Alzheimer's disease. B. Pick's disease. Frontotemporal dementia. C. Creutzfeldt-Jakob disease. D. HIV dementia.
Okay. What would be your answer?
HIV.
Okay. All right. Anybody disagree with that? Okay. So remember that testing is a skill, right? So you have your knowledge, understanding of the content. You can really understand the content and still fail the test because of testing taking strategies or not reading the test correctly. Like a question like this, right? You can say, which of the following is a type of cortical dementia? And you're like, oh, Alzheimer's, right? When it's asking which of the following is not a cortical type of dementia. So just be careful with things like not, only, very strong words, or that kind of twist the question. You could easily miss a question because of not pay attention to one questions. Yeah, a very small, you know, yeah, very small word. So just be careful, okay? And this is why taking the diagnostic test is so important because it gives you a chance of taking 175 questions timed, right? So if you are going to run for a marathon and you only do sprints of 3 miles or run some days of 5 miles, or some days you even run 7 miles and you feel good, you'd be like, yeah, I'm good for the marathon. I've been training for months, 7 miles, right? Short sprint. I feel excellent. Well, a marathon is a lot more than 7 miles. So it's like practicing questions that you do, but you never get to take the diagnostic test 1 or 2. You are missing out on this full content at once. It's very easy to get tired when you take 175 questions, right? If you only take 20 questions, 30 questions, you're like, I got this. Well, yeah, most likely, but do the diagnostic test. Okay, don't skip it. The thing is that, as I seen in the last 5 months, we had about 500 students that took diagnostic test 1. And guess what? Only 250 took the diagnostic test 2. And that is a crucial mistake. Okay? Don't skip it, the test. So, which of the following dementias is most common? Alzheimer's, vascular, Lewy body, Huntington disease. What would be the answer choice?
Alzheimer's.
Okay. Can you tell me a little bit about Alzheimer's? What do you know about Alzheimer's?
Decrease in acetylcholine.
Great point. Is it cortical or subcortical?
Cortical.
Cortical, okay. And it is the most common type of dementia. Thank you. Vascular dementia, right? What do we know about vascular dementia? Anybody can tell me a hallmark of vascular dementia? Choroidal fluids, right? What else? Anything that has to do with go ahead, please. Carrie?
Endoscopic abnormalities.
Perfect. Yes, absolutely. Okay. Lewy body.
High blood pressure.
High blood pressure. Excellent. Excellent, right? Vascular. So very good. How about Lewy body? What's the hallmark of a Lewy body?
Visual
Visual
hallucination.
hallucination.
Visual hallucination, not to give antipsychotics, okay? How about Huntington disease? Does it fall under cortical or subcortical?
Subcortical.
Subcortical.
Excellent.
But
okay.
isn't it
Right.
a genetic disease?
Yeah, that is a genetic disease as well, but it falls under subcortical. Excellent. Yes. Okay. So Alzheimer's is the most common. We mentioned that it's a cortical. We mentioned all that. It's gradual acetylcholine deficiency, right? Okay.
I have a question.
Yes, please go ahead.
So what, yes, sir. So what is the Lewy body under? I'm not sure. Is it subcortical or cortical? Does it?
So the Lewy body doesn't really fall under cortical, subcortical. It falls kind of under its own. But what's important about Lewy body is that
Okay. Visual
hallucination and do not give antipsychotics. Okay. So promise you, if you get a question on Lewy body medication, for answer A will be given antipsychotic due to the hallucinations to trick you. Okay. Very common tricky question. In subcortical dementia, you would expect what? Aphasia, extrapyramidal symptoms, hypersexuality, or carotid bleeds. What would be the answer?
extra.
Extra, EPS, and depression, right? All right. Okay. All right, may I have a reader here from me, please? Anyone?
The question.
Sorry, I guess that was the answer, right?
Yeah.
Sorry. Okay. Okay. May I have someone to read this question, please?
Which disorder involves the frontal lobe of the brain? A. Huntington's disease. B. Parkinsonian disease. C. Vitamin 12 deficiency. D. Pick's disease.
Pick's
D.
disease.
Pigs.
It's
Okay. It's
Mm-hmm.
it's Pick's disease of frontal or I'm sorry, cortical or subcortical?
Cortical.
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 Cortical. Okay. All right. So yeah, Pick's disease involves our early personality, right? So it's frontal personality. Every time you hear frontal, think about
E.
personality, okay?
Yeah.
Behavior change, language changes in the frontal lobe, right? So Pick's movements, okay? And this one that's our early stage symptoms, personality change, cognitive change later, and then there's this weird uh well, Bruce, I want you to look it up on YouTube. It's fascinating, okay? You'll always remember. It's very rare. So a patient with HIV may experience which type of dementia? Could be cortical, mixed,
Subcortical.
subcortical,
Yes.
or none of the above. All right, subcortical. You guys are on point. Okay.
Mm-hmm.
All right. So, and remember, every time we have a HIV or a drug user that do injections, first thing we want is collect an HIV lab. If we have someone with HIV, the first thing we want, now it's confirmed. Now we want to see the phone. We do not want to do anything or any psychotic drugs just yet. The only thing that's going to help this patient is a antiviral load. Remember that, okay? So early stage, cognitive decline, motor abnormalities, lack of coordination and behavior abnormality, right? Later we see autism, seizures, and hallucinations like, okay. All right, so this is the end of what we missed yesterday.
Did we lose Dr. Lopez?
Yes.
All right, I'm back. Sorry about that. Can you guys hear me?
Yes.
Yes, I got kicked out by myself. So now we are going to play a game of Kahoot. Uh, anybody needs a break or we go to start?
5 minutes?
5 minutes, okay, 5 minutes, fair. All right,
Okay.
it is let's call it 7:10. Come back at 7:15, and then we start this game, okay? Or at least we get things started at 7:15 p.m. Dinner time. Go ahead. Please ask your question if you have one.
Yes.
What's the pass? What's the keyword? I don't.
Yeah, I'm gonna show you as soon as I come back.
Oh, okay.
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 All right, guys. So I'll be back at 7:15 Eastern Standard Time. See you soon.
How do I log into the Kahoot?
Say it again.
I'm trying to log in to be
Yeah,
able to participate.
you can't because actually I'm gonna show you right now, and you guys can start logging in. That's a good idea. Well, let's go ahead and show you the password and then get things started. So we're actually gonna play um what I had planned for last week when I couldn't come to the live due to a surgery. We're gonna play module 1. Next week we'll play module 2. Okay. 1 second, and I'll share my screen. Right. So actually, let's come back at 7:20, okay? 7:20, just so that gives us a good break and then we get started. If you know how to log in, go ahead and log in. I'll come back a few minutes early and help those that have not played the game. Thanks for the water. Quem é mais sua equipe? Quem é? É a Vitória? Ou é a Valentina? Tá bom, tá. All right, so I'm a little bit early just to get those that have not played the game, help them log in. Is there anyone that has not played the game and would like some help? Everybody's in? Everybody's good?
I'm not sure. Get in.
You're not sure if you are in?
No, I'm not in.
Okay. So do you have a computer and a cell phone?
Yeah.
Okay. So you're gonna watch on your computer and play on your cell phone.
Oh.
On your cell phone, you can take a picture of the QR code. I mean, not take a picture, just put your camera there and then click on it. What do you see?
Is there like login?
And come with a phone with a QR code.
Yeah.
Phone for scan on QR code. Oh, yes,
Yeah,
I am too.
Yeah, when you put your camera right here, next to the number.
QR code, and I feel good.
Right here.
Your phone scan QR code.
I'll just
What? Your phone scan QR code. Yeah, but
Oh,
I'll just
no, it's okay,
you're supposed
Michelle.
to scan it and go to one other, go to
Yeah.
the side.
Because it's space, that's why.
Right, the picture
Live
is
mic.
QR code.
Live mic people.
Yeah, there's a lot of people with a hot mic. If you, so Michelle, you can also go on Google and then type
I'm scanning.
kahoot.it, not .com, and then it should ask you for your PIN code. The QR code is actually easier, but you can do also the www.kahoot.it. I would love to have you participate rather than watch. It's very fun when you participate. And there's a friendly competition, right? So I say that diagnostic test 2, if you score more than 80, you are ready for your test. If you score more than 80 the first time, right? Not the second, first time. Also, an indication of preparedness is winning the Kahoot, right? I had someone that just passed last week. She said the first time I played, I scored like very low, 22, and then I improved 15 and 6 and until the first place, right? So it's a good indication. If you were, if you're a top scorer in the Kahoot, between 20, 30 people, that means you were really getting close. Now, on the test day, a lot of things can influence your score. to include your own anxiety. So being able to control your own anxiety is important, and we have some techniques that can help you with that as well. Okay. Now, Michelle, were you able to log in, or where are you at in this process?
I'm trying to do that. So I'll use
I cannot hear you, Michelle.
just trying to see password you said.
So yes, do you need a password?
Okay, so is it the same password we'll use to go in doing the courses or the modules?
No. So this is not part of my course. It's a Kahoot. So you have to go to www.kahoot.it
I
to
did,
participate. You did.
but they're actually asking.
You're breaking up. I can't hear you.
They're asking for a login. So
So log in. It'll be a password, right? I mean a pen game.
no,
Can you? I don't know if you can share your screen, but
It sounds like she's using an app, not Google Chrome.
yeah, exactly. So can you just use Google Chrome, not an app?
yeah, that's good.
You did?
Let's get.
Okay.
I'm almost done. So we don't know where it no.
I'll
Yeah,
just
can you scan the?
I'll
You just
scan it
want to
for
watch
you.
this time?
Fine.
Yeah. So at the end, I'll show you how. So let's get started. If everybody is okay with that.
thank you.
All right, man. Sorry we couldn't help you. It happens sometimes. But let's get started then. All right, guys. So remember the Kahoot. You watch on your screen. You play on your phone. You get more points for being correct, and you get more points for being fast. Let the games begin. Good luck, everyone. There'll be 30 questions today. Okay, a little bit more than most. Now remember, for the answers on a Kahoot, I have to shorten them. I have to mute yourself, please. Remember, I have to shorten the answers because the Kahoot only allows me few answer choice. If you have a question, go ahead and ask yourself. Unmute.
What's the pin to get in? The game pin.
Oh, I do. Anybody remembers that? Oh yes, 674-1711. 674-1711.
Thank you.
Mm-hmm. All right. Actually, you guys killed this one. I was expecting more incorrect answers. So you guys are on point, okay? So let's take a look here. Who actually Psych NP? She just took the first place right away. Ebony, and then Pam, KD, and Jean L. All good job. Good job, everyone. Actually, 22 answers were correct. So that's fantastic, right? So serotonin and norepinephrine, right? It's the correct choice. Both serotonin and norepinephrine are implicated in mood regulation and are commonly associated with mood disorder, right? So low levels of serotonin, we think of depression-like symptoms, even anxiety. But while imbalance of a norepinephrine can also contribute to anxiety, right? So with a lot of norepinephrine can also be agitated, so anxious. So the patients present with depression and anxiety suggest the involvement of both neurotransmitter and most of these neurotransmitter. Now think of a GABA, right? GABA also has to do with anxiety. If you have a very low GABA, you could be more anxious. But if you have a high GABA, you'd be slow and everything. It's okay. right? Relaxed. Dopamine. If you think about dopamine, I like to think about rewards or money, right? Not really money, but like rewards, motivation. Think of dopamine, but it is not the primarily neurotransmitter involved in depression and anxiety symptoms. Well, maybe not the primarily, but I like in practice to mix a little bit of dopamine, norepinephrine, and depression when possible, just to make sure I'm covering all the three neurotransmitters. Okay, good job, everyone. Please, if you have a question, go ahead and ask.
Yes, so the pin would be 674-6711.
6741711.
1711. Okay, thank you.
Absolutely. There was another hand raised. Please ask your question. I cannot see your name, but if you have a question, it's a good time to ask now.
Is Psych NP already certified?
Say it again.
That person who is number one, Psych NP, is that person already certified? I'm trying
Well,
to get, I'm trying to get
she's
certified.
about. She's already. She's
What?
already claimed it. She already is. I promise
Nah,
you.
tell us to playing.
Yeah.
Oh no! Oh no, I'm not.
No. Yes, you are. You are.
Yes,
You
you
will
are.
be. You
I have
will
a question.
be. Go ahead. Ask your question.
So, Dr. Lopez, does
Hey,
it
you gotta
Yes.
be positive.
No.
Yes. All right. Unmute yourself, guys. Mute yourself, please. Go
so
ahead, please, man.
does it pick your score from the last time we did the Kahoot? I don't
No.
know.
This is a new game, so it doesn't keep any score from last time.
Oh, okay. So if everybody had the right answer, why am I at the 15th place?
Because you're faster.
Oh,
You get points for being faster, and you get points for being correct.
oh, okay. Thank you.
Okay. All right. So let's go back actually to the Psych NP, right? I love it because if you tell yourself that you are, you become what you are. Okay. This is so powerful. I do this all the time. Anything that I desire and anything that I want, I get it. Anything. I promise you. Because I claim it, I live it, and I do it. Right? If I say, I want to be a CRNA and that's what I want to be, and that was 10 years ago, and everything I ever did was to be a CRNA. I went to the ICU course, which is in San Antonio for 6 months. I did helicopter training. I did all kinds of trainings in ICU, all of them, and I was like, okay, now I'm ready. I got accepted to the same school that accepted me for the Psych NP course, which is a very difficult school. Super, I would say, super hard school. And then 2 months before, I said, "Hey, I changed my mind. I want to be a Psych NP." And they're like, "What?" Anyway, so the point is, you claim it and you live that dream. You walk like it, you talk like it, and you be it, right? So it's very important that if you say, I will pass the test, and you kind of work that out, you cannot just say it and not do it. You have to really claim it and walk in the test center like it is yours. Nothing else will stop you. Claim it, live it too, right? So you cannot just claim it and not do your work. That wouldn't help. But as you do your work, feel it, understand it, enjoy the ride rather than being preoccupied with passing or not passing. That will be the outcome. But as you, oh yeah, depression has to do a lot with norepinephrine and serotonin. And why? So enjoy the understanding. It will transform your life. Okay. All right. Next question, everyone. Okay. All right. So classic question, at least the beginning of the question. X, Y, and Z was stable for whatever months. Then it came to you with X, Y, and Z unstable. So anytime for any question, this is classic, right? When it starts with being stable and the question twists to unstable, you have to ask yourself why. What happened? Especially with lithium, especially with antipsychotics. Very true. More true with lithium, as they would say, patient was stable in few months or a year. You always have to ask why. And then you see that another provider added the medication. So what you do? You have that choice of calling the provider or have the choice of increasing your medication, especially if it's antipsychotic or mood stabilizer. In this case, it wasn't it, but this case was it that it was stable, something happened. It was the increased lithium level, right? But pay attention on the stable and become unstable and look to see if there was another provider adding a medication to this or how the patient became unstable. In this case, was a increased lithium levels, right? So normal values 0.6 to 1.2. So here's the catch, right? When it becomes 1.3, what do?
Continue.
Monitor.
Monitor.
Yes.
Monitor.
So you do not stop the medication. You monitor the patient. If the patient has no symptoms, you continue the medication. How about 1.4?
Continue. Monitor.
Continue to monitor, right? How about 1.5?
Discontinue.
Monitor.
Stop.
Discontinue.
Continue.
Okay.
Stop.
All right. Somebody said monitor. Why would you say that?
Oh, you said
It's
1.5?
okay.
Oh, I'm sorry. 0.6
Yeah.
to 1.2. I'm sorry.
Okay.
Discontinue.
No, it's okay. No, yeah. So 1.5, you discontinue. You keep it at 1.3 to 1.4. But you assess the patient. If the patient is symptomatic, you discontinue. If the patient is asymptomatic, then you continue. Now, guys, this is only for test and specifically for the board, right? In practice, it's very different. Okay, so don't think this is a fast rule. Dr. Lop said this is what. No, okay, this is only for tests. The test is very different than life. Okay, in life you do as you learn and you use your clinical judgment, but for the test it's very black and white in certain things, especially numbers, right? Go ahead, ask your question, please.
Okay, Dr. So at 1.6, you discontinue with symptoms, right? And you said
No,
1.5.
no.
Okay.
1.5 and 1.6, or anything above that, you discontinue totally.
Okay.
Okay. 1.3, 1.4 with symptoms. Because that's
Discontinue.
with symptoms. No symptoms, you continue the medication.
Okay.
Am I clear or not?
So at 1.3, since, okay, so I was looking at the range 0.6 to 1.2. So at 1.3 without symptoms, continue, 1.4 continue, but 1.5 with symptoms, then you discontinue.
1.5 with anything, you discontinue.
Okay, I got it.
Okay,
Thank
so it starts at 1.5 to be critical.
you. Okay. Okay, thank you.
Now, this is for the board, okay? Practice will be very different, guys. Don't freak out in practice. In practice will be very different, okay? Now, and during our classes, is the time to ask any question, right? The only silly question is the one that you didn't ask and you got it wrong because you didn't ask. That would be silly of you, okay? So, got a question, please ask.
Go.
Okay, so here we have it. Ooh, a lot of serotonin. We're thinking serotonin is definitely involved. Now, is it the norepinephrine or dopamine, right? So let's take a look here. Psych NP, she's claiming it, man. She's fast. Okay, so patient presentation, right? With the recent depressive episode, we know this is most likely serotonin. So periods of elevated mood is consistent with bipolar, right? So bipolar is a mood disorder characterized by altering periods of depression and mania, right? We're clear here. Okay, good. Now, serotonin and norepinephrine are the two main neurotransmitters that have been implicated in a pathopsychology of bipolar. So the imbalance of these two neurotransmitters are thought to contribute to the mood fluctuation experienced by individuals with bipolar. Guys, this is only for test, okay? Only for test. No one in practice ever talked about the imbalance of a serotonin and norepinephrine for patients. Never heard of that in practice. This is test. This is very different than what we do in practice, okay? Now, is it only the two? Is dopamine not involved? This is incorrect. Dopamine is involved, but it's asking the main players. So all the neurotransmitters are involved, in fact, but not at the higher level as, in this case, serotonin and norepinephrine. Okay? So serotonin involved the regular mood, sleep, serotonin, very important. Appetite, and a little bit of cognition, not that much. Low levels of serotonin have been linked to depression, while high levels have been associated with mania. This is why if you give a antidepressant medication to a patient that you did not screen properly, that came to you as depressed, but in fact is a bipolar 2 or 1, and you give a Zoloft, Lexapro or whatever, you could throw them into a manic stage. Okay, so don't give antidepressant to a patient with a family history or presentation of mania. Now, norepinephrine, right? So when you think of a norepinephrine, we think of a fight or fly, right? Response that regulates attention, arousal, mood. So imbalance in norepinephrine can also contribute to mood fluctuation in bipolar. So these two are the main players. It doesn't mean that dopamine is not involved either, okay? But when we think about dopamine, we think of cash, right? I would say cash, but meaning rewards, right? Chocolate, the other things that feel good, okay? So, but these two, norepinephrine and dopamine involved with the bipolar symptoms. Right, there was a lot of confusion here in this question. I get it. Sometimes it's hard to define which ones are the main player, but in reality, all the neurotransmitters are involved. It's not just this two, it's an imbalance, completely imbalance of all neurotransmitter. However, bigger players, serotonin and norepinephrine. So here you go, classic. Had been complying with lithium, was stable on lithium, blah, 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 stable on any medication, but something happened. However, presents with tremors, nausea, confusion. Something happened, something changed. What was the change? Coarse hand tremor, I talk about this all the time. You can see tremors is coarse, which means it is toxicity, right? All right, we have 8 seconds. I trust and I hope, and I don't mean to say this, but if you were fast and picked the wrong answer, I get it, right? If you actually thought there was another condition, I would highly, highly encourage you to talk to me and we can discuss a little bit more after the course. This was a clear presentation of toxicity, right? Of lithium toxicity. So maybe I can be of some help, okay? All right. So this is the lithium toxicity symptoms, right? It can include tremors, nausea, confusion, hand coarse. If you see fine hand coarse, you wouldn't see fine because fine you can't see, but the fine hand coarse would be a side effect of lithium. Coarse you can see. Now it is a toxicity or signs of toxicity. It could be toxicity, right? Very classic sign, right? The symptoms occur when the lithium level is high, usually above 1.5. That's toxicity level. 1.5 is toxicity level, right? Serotonin syndrome is typically associated with a certain antidepressants. So here's the thing. For the question, it never talked about serotonin or antidepressant. It's talking about lithium, right? So the question could only be answered by lithium. So let's say you are a high schooler and you just walked in and you are going to take that question. What I would tell him is that look at the stem of the question and pick a word that's in the stem of the question and the answer or something that's similar. So there you'd have lithium. You look at the answer, you would have lithium toxicity. So blindly, if you don't know the answer, at minimum, try a test taking strategy that could get you higher than a 50% chance, right? So benzos, we never talked about benzos in the question, but we present those symptoms of anxiety, insomnia, benzo withdrawals, obviously. Hypothyroidism can actually shows like depression-like, right? Not necessarily hyper. That would be more manic-like. Guys, remember, in Kahoot, I can only put a small, short answer. So the answers oftentimes will be incomplete and maybe hard to understand. I can only have like very small sentence. Okay, so if you have a reduced renal clearance, so your renal, your kidney cannot do its job, so therefore more lithium would be in the body, right? So lithium may be higher due to the decrease, not increase, decrease of renal clearance. I need you to understand that, like fully understand that. You will get at least 5 to 10 questions on lithium. So it's anything that decrease renal clearance equals to an increase in lithium levels. So alcohol use can lead to impaired renal function, since lithium is the primarily excreted by the kidney. Decreased renal can result in higher lithium levels in the bloodstream. So While alcohol metabolism can cause various effects on medication, it typically does not lower lithium level. In fact, alcohol can potentially raise lithium level by affecting affecting the renal function, right? How? Well, diuresis, right? So alcohol has no effect on lithium levels directly. This statement is not accurate. So alcohol, lithium is a commonly used medication for bipolar, as we know, but it may be necessary for patients with a history of alcohol use disorder. So any medication that causes diuresis could affect lithium level indirectly, right?
So alcohol is an inducer. Should we say so?
Well. I can't stop the question now, but we'll
Okay.
go back to that.
Okay.
It could be an inducer or inhibitor, depending how much is drinking. Dá beijinho, papai. Okay, so before we actually go to this question, I want to answer a very classic mistake here. So somebody said alcohol is an inducer, right? So here is where the mistake happens. A lot of students get fixated on inducers and inhibitors. Okay, please mute yourself there if you can. So I teach this on the strategy. I believe in the strategy, or even on the inducers and the inhibitor course. Not everything is about inhibitor inducers. So when students get so fixated on neurotransmitters, what are the neurotransmitter X, Y, and Z? You're only gonna get 1 or 2 questions on that. But inducers and inhibitors are another point where people think about everything they see is this an inducer or the inhibitor? When it has nothing to do with that. Remember, especially on the patients who are stable, X, Y, and Z added something, it'll be a clinomycin. And then the student will look at that like, oh yeah, I know this is a inhibitor or inducer, and therefore it's going to do X, Y, and Z on the other medication. Automatically, most of you guys, or not most, but some of you guys will think that way. When in fact, has nothing to do with inducer or inhibitor. It has to do with that medication causing a depression, causing a bipolar, mania-like symptoms, and therefore your action is to increase your medication or call the providers to see if they can reduce or change their medication. Okay, so not everything is about inducers or inhibitors. But answering the alcohol, it can be an inducer or inhibitor, depending whether it's alcohol abuse or chronic usage. Okay? Just want to put that out because it's so important, and I see it like on a weekly basis. The question, this is an inducer. Yes, go ahead.
Oh, no, you are going to explain that. I thought you were skipping. Okay.
Yeah. So lithium mechanism of the action is really unknown, right? But it reduces suicidal ideations involved in the modulation of glutamate. So only for those patients with bipolar, right? Is known to, or book says it does, right? So the action is associated with a decrease in the impulsivity and aggressive behavior, making it a valuable choice for patients at risk of suicide. Okay, all right, moving on to the next question. All right, classic one. Patient was doing well, and then something happened. Remember, on Kahoot, I can only put small sentences, so some of them will be incomplete and may not necessarily be the best choice, but it's the one that I could write it down. So everybody got this correct. It was pretty straightforward, but nevertheless, all of you guys got it correct. So good job, excellent job. All right, presents with coarse hand tremor, classic. What does it mean, right? And confusion. What would you do? Discontinue lithium, order a complete blood count, administer benzodiazepine, or increase the lithium dosage, right? So anytime you see, for any medication, anytime you see a toxicity level, what would you do first? Right? Anytime you see a toxicity level for any medication, your first action is to discontinue the med. Again, we're only talking about test strategies here, right? Anytime for any medications, you do not get the lab first. Oh, should I get the lab? No. If you think it is, stop the medication. Lithium, lamotrigine, carbamazepine, you name it. You don't have to have a lab to stop. You'd rather be wrong and continue the medication than waiting for the labs and then causing more harm for the patient. Okay? All right, everyone got it right, so I don't need to even talk about it. So get some water. All right, guys, excellent job there, right? So here's another classic one. When the patient presents with a antipsychotic and has changed and is stabilized, if they is stabilized, you do not, this is actually for real life too, you do not destabilize the patient. You want to first offer a exercise or life change style before you do any kind of a medication change. It's so hard to get a patient stabilized. You do not want to risk switching the meds due to metabolic syndrome or other things. If it's stabilized, try to do a lifestyle modification first. Okay, excellent. So if you change an antipsychotic to reduce metabolic effect, it is a good choice, okay? But remember, do not destabilize the patient. If the patient is stable, okay, work on exercise, lifestyle modification, and especially involve a nutritionist person because you want to collaborate. Collaboration is so important. So any research choice that has a collaboration, not telling them what to do or them telling you what to do, definitely not, right? If there is a collaboration plus a lifestyle change, it's always the best option to begin with, right? For tests specifically. Here we go. Patient has been compliant, stable. Now something happened. What happened? The patient now reports persistent diarrhea, nausea, and confusion. What is the most likely cause of this symptom, right? So here, it's a lithium therapy. So do not pick serotonin. You got to pick something with lithium. Okay, this one. All right, so take a look.
How can that be right? Because it said confusion. That's not gastrointestinal.
That's my question too.
Okay, so let's take a look here.
I think it's a bad question.
Yeah. So include the persistent diarrhea, nausea, and suggestion of a lithium-induced gastrointestinal side effect. So all right, so let me kind of clear up a little bit, right? So it is a confusing question. It could have been written better to begin with. But here is when I think the confusion is. If we talked about lithium-induced nephrotoxicity, is more associated with renal impairment, right? So it's associated with NSAIDs, ACE inhibitors, or any medication that's secreted by the kidney, right? Especially NSAIDs, ACE inhibitors, blood pressure medication, heart failure medications, right? So I think the question could have been better, but overall, it's more of a lithium-induced gastrointestinal side effect. Just because it's confusion itself, because it could have a gastrointestinal side effect and still cause confusion, which is more central, right? Not necessarily gastro or in nephro toxicity in this case, right? So lithium is not typically presented with lithium symptoms is unrelated to lithium is not typically presented with gastrointestinal symptoms, but okay. All right. So how do I go back? Okay. 1 second. Working with one eye only is confusing for me. Oh my God. Remember, Kahoot, I can only put a small answer. So a short answer left. Ooh, okay. All right, so let's take a look on this one. I think I may have keyed in incorrectly. Educating the patient on common side effect of lithium, including weight gains and increased thirsty, and emphasizing the importance of monitor is essential, right? So abrupt discontinuation of lithium without considering alternative can pose a risk, so we wouldn't do that. Recommended discontinuation without exploring alternatives and considering the patient ability is not the first line approach. While hypothyroidism is a potential side effect of lithium, we know that it does not typically present with increased thirsty alone. So here was the tricky part, right? So switching to alternative mood stabilizer is a consideration, but education of the patient on the side effect and monitor should precede any decision about changing the medication. So on the question bank, I have different types of answers. So on Kahoot, I can only put small or short answers. So that might cause some confusion. I'm trying to put an answer that leads you to the correct or incorrect answer. But on the test bank, we have a more complete answer choices. Okay.
Got a hot mic there somewhere.
Dr. Lopez, I think, has it.
All right. So elevate lithium level toxicity and titrate the dose accordingly. So let's take a look here. So the people that pick discontinue would not be incorrect. It would be a correct answer. Okay. So yeah. So anytime you see toxicity, you want to discontinue immediately. So that would be the. So really, it was a mix of both. So this question would not be a valid question, right? Because you want to titrate the dose anytime you see a high lithium level presentation. But the first thing you're going to do is really stop the medication, especially for the test. So this is actually a mixture of a test question and a life situation. In life situation, do you think we would stop the lithium? Probably not. I'm telling you, they wouldn't. I've seen people with 2.2s and they still keep on giving the lithium. Not me. But for the test, you would stop the medication would be the best option here.
Question on this one.
Yeah, go ahead.
I lost my point there.
Uh,
I wrote it to continue, but I didn't get no.
guys, someone has a hot mic, so please only 1% at a time. Go ahead, ask your question.
She's wanting to stop or change her med for a theoretical problem that hasn't even presented itself. So I thought education was the only first choice.
I discontinued the medicine.
Leukocytosis.
So,
I didn't get
yeah.
no point.
Have a problem yet?
Can I say something real quick?
Yes, go ahead.
I think it's more because there's two type of tremors. Like one is just a side effect,
And one
then-
is?
and one is toxicity. So the course
Right.
is the toxicity. So I think that that's why this question was leaning more towards the titration.
Right. The Zelina motors. But if you have a course, right? So that's why I was leading more to both answers, discontinue and titration, because you say titration really is to reduce the dose, right? And the discontinuation is because of the tremors.
Should we assume with persistent hand tremors mean cause hand tremors? It didn't say cause, it said persistent. Is that interpreted as cause hand tremors?
No.
No,
No.
It didn't say cause, it didn't say toxicity.
I can't go back to that one, but I maybe at the end I will, and we can take a look on the question, okay? Let's move on. It doesn't allow me to go back. All right, patient being stable on lithium starts the classic way. Dark urine. So the core of the question is how dehydration affects the lithium level. Oh, it doesn't. All right, perfect. You guys all got it, so we'll keep on moving here. Psych NP, she's on fire there. 3 in a row, 8 in a row. Oh my. Right, dehydration can decrease renal perfusion, right? Leading to a decrease in renal, decreased clearance of lithium. So have a decreased lithium clearance, it leads to an increased lithium level, right? All right, classic again. Stabilized on lithium. So what happened? So this is a classic one where people would be like, is this a inducer or inhibitor? One that has nothing to do with inducer inhibitor. I know we're talking about NSAIDs, but let's say this was a antibiotic. And then people would go straight to inducers and inhibitor one that has nothing to do with that. Okay? So pay attention. So in cases like this is a classic format of question. Okay, so NSAIDs can almost double the lithium levels, right? So it may increase lithium levels by reducing renal clearance. Any medications that is excreted by the kidney has the potential to increase lithium levels, okay? Honey, Natalie, and Jean, and Loli, they're all on fire there. Okay, so we got most this one correct. High yield NSAID and lithium do not go together, okay? For the test, okay? In practice, that doesn't even apply. It's not even a consideration. A lot of things we talk about here, it does not apply in practice, okay? So hyponatremia is expected, but not nausea and confusion. All right, you guys are good. Well done, everyone. We have quite a bit of questions today. We'll keep on moving, okay? So patient stabilized only, then what? Then something happened. All right, so hypokalemia may increase lithium levels by reducing renal clearance. Okay, so increase lithium levels, right? Hypokalemia can increase lithium levels by promoting lithium excretion through the kidneys, potentially reducing and decrease lithium level there, right? So monitoring lithium levels is important for the presence of hypokalemia, right? Okay. So here for a need for more education, right? So we're looking for the incorrect answer. All right, excellent. Yeah. So all right, so a little bit of confusion on this question. Sorry about that.
I don't even know which one to pick.
Very confused question.
Yeah.
Can we throw that one out?
Yep. But hold on a second.
Nope, it
All right,
won't throw them out.
Yeah, it doesn't allow you to throw out. So sorry about that, guys. So we'll
Supposed
go
to
ahead
be
and,
the same time of the day, right?
yeah, same time of the day, usually in the morning. So do
The morning.
apologize about this one. Yeah, so
Yeah, technically before medicine, usually every day, like usually regular time, you know.
yeah, preferably in the morning too. Okay. Yeah. All right. So everybody got it. All right, you guys are all fire here. So be careful every time you have lithium and hydration, right? You're working outside or taking extra salt or anything like that would be a teaching question that you need to really know.
Hot mic.
All right, so idea here, remember, Kahoot doesn't allow me to put a lot of words in it, right? So the idea here is to really take lithium with lots of water to ensure hydration, okay? So now a more of a full answer would be on the question bank. So taking lithium with a full glass of water is advised to ensure proper absorption and minimize the risk of irritation to the gastrointestinal tract, okay? So that would be more of a complete answer.
Red Par, you have the hot mic.
All right, you guys are on fire here. Okay.
Even if I don't stay there, I'm happy.
Red Par, can you put your mic on mute?
Yeah. Sorry, I skipped you there. I can only stop on the next question. So once this question stops again, go ahead and unmute yourself and ask your question. All right. So instruct the patient to stop taking lithium in the order and lithium level would be the best option.
But again, they didn't have coarse hand tremors. They didn't have severe nausea and vomiting. They didn't have toxicity symptoms.
Well, I wish I could go back to the question. I can't necessarily tell you.
I saved it.
It was persistent.
Persistent. There we go.
Yeah, there was persistent nausea, hand tremors, and increased thirst.
Okay.
That is not toxicity.
But it's persistent, right? If you have, think of this way, if you have persistent hand tremors, nausea, and vomiting for 3 days, say only 3 days. The question didn't say how many days. It said persistent. Anytime you have persistent, excessive, other words like extreme, is really telling you to stop the medication. So, although I do think that the questions will be written a little bit less confusing on the test, but I can almost promise you that they will be confusing. There will be words that are not extreme, but lead you to a stopping of this medication. This actually would be a very good question because it says persistent. Okay, I think Rebecca, you're not wrong. Okay, you're not wrong, but the wrong part is only that for test, they will not give you a clear cut. I used to think, you know, very concrete, especially for diagnosis. For example, this is how I would think for diagnosis. All right, you need 5 symptoms for major depressive disorder for 2 weeks, and then you exclude medications and out of the disorder. So I would be looking for 5 symptoms for 2 weeks for me to call it a major depressive disorder, right? And guess what? It would never happen because the test would never tell you, never, in no conditions, it will give you the full symptoms. Almost at the end, it ends with the most likely diagnosis, the most likely condition, priority, right? So just you're not wrong, Rebecca, but I think you're being more concrete thinker, like I was expecting to
Yeah,
see.
I memorized lithium toxicity. I have a mnemonic and everything, and
Right, but you are missing the point of persistent, or
persistent.
persistency, or continuing. Things of those natures is leading to, think of someone being dehydrated for 3 days. What would that lead to? Toxicity. Even though the symptoms are not there, but if it's persistent.
Okay. And I'm not thinking test thinking, I'm thinking real life. Patients
Right.
have persistent nausea. That means they were nauseous yesterday morning. You
Right.
know, that define
But
persistently, but not on the test. Persistent.
right. So if you say nausea yesterday morning, so you would be able to ask more questions. Have you had
Yeah.
more, but the test will not give you that. They will just give you hints. And then you at in the end it would be like the most likely priority or condition that you would do. So just be careful because you're being correct because you understand what it is, but you're being fixed on that box. So you have to be like me, get out of the box and be like, okay, now I know that I'm being too concrete, too correct, and that's actually being wrong. Okay.
Okay.
I did that. I did that especially with diagnosis. I did that all the time, especially with major depressive disorder. But then I was like, okay, now they wanted the most likely. So most likely would be X, Y, and Z. Okay? Good discussion though. Good discussion because that is what leads success in the test versus even though you know and you have the knowledge and you feel ready, you may not achieve the results because of a fixation or a way of thinking that's different than a test maker's.
Yes, it's like you have
Present.
to learn to exercise your knowledge. You put the knowledge in there, but now you need to give it a workout.
Yeah. And
Yeah.
in the perception of the test makers, which it makes the next difficult point, right? So we have to think like the test makers to achieve the results.
Oh, I don't
Very
know.
good discussion. Yeah. So it's an extra step there.
Is
Right?
there crazy?
I'll mute you there for a second, okay, Rebecca?
Okay.
Right. So anytime, anywhere he is severe, it's a problem. All right. So anytime we hear severe, persistent, is leading to a problem. So we have to stop, right? So discontinue antidepressant and continue the mood stabilizer. Probably not a best option. Okay, so if you're going to discontinue the mood stabilizer until you figure out what is going on, it's okay. It's not going to make a whole lot of change. At this point, we have a problem. We have a major problem, hypertensive crisis, right? Systolic blood pressure is over 180 and diastolic is over 120. So it is a hypertensive crisis. So discontinuing both antidepressant, both the antidepressant and the mood stabilizer immediately is the priority action in the presence of hypertensive crisis, right? So that patient will need to go to the ICU most likely to control his blood pressure. Can be done in the ER as well. So oh, good question. Severe headache. Anytime we hear severe, that means something. This one's going to get a lot of people too. All right. So let's see why. Okay. So discontinue the MAOI, so it will be misspelled there, right? Incorrect. Immediately is the priority, right? So that's what you want to do in the presence of a hypertensive crisis, right? MAOIs can increase with certain foods and medications. So I do apologize for misspelling the question there. The answer, leading to a potential life crisis in the blood pressure. Prompt intervention is necessary to prevent complications. Now, so administering hypertensive medication is important and it is a priority, right? But think of this way, would you do that before you discontinue your MAOIs? No, right? You discontinue the problem before you address without a solution. But the immediate priority is discontinue MAOI to decrease due to the hypertensive crisis, right? So I think if I maybe the mistake in the answer there, missing the letter M instead of a D, I believe that may cause you to pick a different answer. But hopefully you understand the point. You want to discontinue the cause and agent before you actually address with something else. Okay, so very good. So
You're going to want to give her folate too, till she gets off
give,
at least.
give her folate. Very good point. So lamotrigine would be a good choice, right? I wouldn't say it's a safe choice, but a better choice than not having nothing, right? Better choice than lithium. Way better choice than carbamazepine, right? Better choice than Depakote. Thank you.
I think this one's a oops.
Yeah, sorry. That was a repeat question. I guess. One of my team members pick my questions and they put it in Kahoot, and sometimes they just don't do a great job. So I do apologize there. Hopefully everyone got it right, got a point. Okay, perfect. Let's move on. Well, it's better than the last question. So last time the person kind of learned, so that was great. Let's move on to 2 more questions, I believe, and then we'll be done for today. Oh. All right, let me skip this one. So sorry.
That was a different question.
Oh, it was it?
Yeah.
Oh my. Sorry.
Yeah, that one was on lamotrigine.
Yeah, sorry. Sorry, guys. I was too fast and I didn't read the question. Just read the initiation. All right, last one. All right, so here you have the keyword excessive. So generally speaking, right, anytime you see excessive continuously is leading to something that we don't want to go to, right? Symptoms described include hand tremor, excessive thirst, and increased urination are indicative of hyperammonemia, a potential side effect of valproic acid. We cover this in a course in excruciating details, right? Monitoring ammonia levels and considering dose adjustment is the appropriate course of action, right? So here you have it. All right, so let's see who took the lead. All right. Senshin Lowly. And first place for today's event is, all right, Psych NP. She claiming that she took the lead. Here we go. All right, so good job there, honey. And the fifth person I missed. Who was that? So good job, everyone. So here's the thing, right? You learn more when you make a mistake. Every time we make a mistake, we learn more and more and more. So it's important that you ask a question. All questions are important. It's important that you really attend the live course. We have everything you need on the recorded portion, but every time we go live, somebody else throws something different. Every time is different, right? The subject is the same, but we learn more and more and more. So if you can, attend all the live classes. The schedule's put out. I know work may be a problem, relationships may be difficult. Someone has hot mic, please. if you can, attend the live classes, because even though you can do all the work online, coming to the live, it give you time to ask a live questions and interact with others. Okay, so I think Yvonne, I believe you have a question there. Yvonne, or I can't see who it is. Please ask your question.
Yes, I just wanted to find out, Dr. Lopez. So I will not be in the live class because I'm going for a funeral. Can I use my phone? Is it possible?
Yeah.
I mean, I can drop my computer.
Yeah,
Okay.
you can use your phone, and remember that we have we're not going to record every live event because then it will be a immense course, but we already have recorded all the modules that are live, and that's located on PDF module 11. Really, the course really ends at module 8, but then I put in a rapid fire, which is meetings with previous students. Then I put in the live classes so you guys can recap and look at it, right? If you prefer that. But yes, you can participate, and I would encourage you to participate with your phone.
Okay. Okay, thank you.
Absolutely. Yes, hi.
It's Sanzi.
Sanzi. Hi, Sanzi. Got your name wrong.
Yeah,
thank you.
No problem.
I appreciate that for sure.
No problem.
Anybody else has a question or answer or concern that I can help you with?
Yes, I do.
Please ask a question.
I have a question. So,
hold on a second.
Oh, sorry, go ahead.
Okay, either one.
Can you please go over number 34?
Oh, I already got off. I'm sorry.
Oh, you already got off? Okay.
Yeah, I do apologize.
Okay.
Can't do it this time, but do you remember what the question was about?
I do have a question.
Do you remember
One second.
about?
Let me finish, Marie. Do you have a question there, Marie? You know what was the question about?
Yes, it was a question about it was a question about lithium and hypokalemia.
Okay. All right. So what about lithium and hypokalemia? What can you tell me about it, or anybody else?
Because
I can tell you what the question asked. I've got a picture of
Go
it.
ahead, please.
A 30-year-old patient with bipolar disorder is stabilized on lithium therapy. The patient develops symptoms of hypokalemia such as muscle weakness and palpitations. How might hypokalemia impact lithium levels?
Mm-hmm.
Do you want to hear the four choices?
So how does, so what was the answer choice, do you know?
Yes, hypokalemia, no. Yeah, hypokalemia may increase lithium levels by reducing renal excretion.
Mm-hmm. Okay, so hypokalemia, hypo, right? Or it was hyper? Hypokalemia. So hypokalemia or low sodium level, right? So it interacts with lithium in several ways, right? So if you look at that, the kidney function, both lithium and potassium are really processed by the kidney, right? So when potassium levels are low, what happens? So the kidney may retain more lithium, potentially leading to a lithium toxicity. Right? So that's the first thing. Now think about what else. How else can lithium and a electrolyte really interact, right? So if you look at lithium, let's say lithium and potassium, electrolyte balances, right? So lithium and potassium can really play a role together in maintaining the balance of electrolyte in the body. Both are important. An imbalance in either can affect each other's levels, I would say, right? So lithium levels, let's say with hypokalemia, can cause lithiums in the blood to rise. Why would that be? Even if lithium does not change, hasn't changed, it can increase the risk of lithium as a side effect. So lithium toxicity, we know it's severe, right? It can interact and lead to lithium toxicity, obviously, which can cause the symptoms mentioned as what it was: nausea, vomiting, diarrhea, and tremors, confusion, or dear mentioned seizure, right? So what was the answer choice? Do you remember?
Yes, I took a picture.
Okay, go ahead, please.
A, hypokalemia may decrease lithium levels by enhancing renal excretion. B,
No,
hypokalemia may have no effect on lithium levels.
no.
Hypokalemia may increase lithium levels by reducing renal excretion. Yes.
Okay, yes.
And B, hyponatremia lowers lithium levels.
Hyponatremia. So you know, right? So we know that hyponatremia, now we're going to sodium. Hypo is going to increase lithium levels. So Maria, what was specifically about this question that I can help you with?
Oh, the question was in the answer, I pick up hypokalemia can decrease the lithium level,
but it can increase.
It can increase it.
Yeah.
So in the like for example, like on the question bank, the way we study that, we have dehydration, alcohol, thiazide, diuretic, NSAID, ACE inhibitor, hyponatremia. They all can increase lithium level. But in the question bank said that the hypokalemia will decrease it.
No, so please send it back to me, the question. I mean, we have over what 1,400 questions. So please, you gotta send to me by email, and the number is specifically which module. So it is incorrect. Yeah. Thank you for mentioning that. Okay.
You explained this really good in last night's live class. You talked about hyper and hyponatremia and understanding the reason why either one can increase your levels, because your kidneys are going to respond to either one about the same way.
Hey, like in the last few days, I have been in so many drugs that I don't even remember. I thought it was a dream. I really thought.
You need to take rest. Dr. Thalis, you need more rest. You need more sleep.
Yes.
Okay.
I have a question.
Good thing I have this on. My wife cannot hear you. Okay, so that's good. Okay, she look at me now. So okay, what's your question, man?
Okay, so I just randomly stumbled on this class.
Okay.
Today is my first day.
Okay.
Like when you say the question bank, the live class and everything, can you give me a little bit of an insight how to join it? Like when is the next class and all of that? And by the way, this is Psych NP.
Oh, Psych NP. Oh, yes, I would love to have you in. Absolutely.
Don't need any classes. You're the top of the class already.
Yeah, she really rocking. Okay, Psych NP, we have a very comprehensive course that is everything together, right? So it comes with question bank, diagnostic tests, a full descriptions of modules 1 through 5, and the crash course review. So that is called the 30 days PMHNP Walk to Success. Now, you do not only have 30 days, you have 6 months of free access to all the live content, plus the recorded content, plus the question bank, plus the diagnostic test, plus the WhatsApp group, plus the community. So plus everything you ask, you have it. Including, I know some people don't use that a lot, the mobile app, is available. Only thing that's not available is the flashcard and the psychiatric and the psychoform, which is separate things, right? But I can give you the link to join. I think you would benefit. I think you're doing well. But when I say this, I don't take it lightly. I think this is the most important test of your life, right? And if that's true, why would you want anything less than a very comprehensive course? To me, that's almost craziness. I would not walk in the test center not being prepared, right? And so that you know, I studied for almost a year before I really walked in there, and I was like, I'm gonna get this 175 questions, each one of them correct. And I don't expect everybody to be that way, nowhere near that. I think that's too excessive. But you know, I expect that everyone walking there with a mindset that you will pass. It's just a normal day. That day of test is just walking in like in a supermarket, buying something and walking out, buying your coffee and going home with no doubts in your mind. And that is my expectation, that each one of you, you know, come to that mindset. It's just like ordering a Coca-Cola at the McDonald's, getting you what you need and walking out. There will be no failures. The mindset, right? But you only get that mindset when you do it again, fail, do it again, fail, do it again, fail. And then like, okay, now I'm doing it, and get every single one of them correct, right? So study hard, guys. Study hard. Start like you mean it. Start like it is the most important test of your life. You know, every day, claim it, walk like it, talk like it, be like it. And if you do that for a short period of time, you know, maybe 30 days, maybe a little bit longer. Some of you guys are longer. Some of you guys are in school. And as soon as you finish your school, a lot of people just like the next week they pass the test, you know. But they've been doing that like for almost 6 months. They signed up while in school and then just kept attending the classes. And, you know, like Seashell was in school. And she's like, Dr. Lopez, I'm graduating next week. So when should I take my test? I said, the next day. Because you've been attending all the classes and doing all the things. And next day. And she just did that. Next day she went, so like, yep, done, right? Now we have some people that may be with us for a while and have not taken the test too. That's okay. But we got to find out if it's something holding you back, right? What is holding you back? So if you need to talk to me, please email me. And if you need someone to talk to, I'm available as well. We have some people that are doing studying groups, which I love it. But be careful that not to be a cloud of smoke, right? That you're using as a reason not to test or a reason to hide behind. I had a student that she was doing study groups for a long time. Everybody on the study groups was passing, and she would not take her test. You know, and then she was about to take her test, and I said, please don't do it. You're not going to pass. And then because I looked at her diagnostic test and I said, you are very close, but I would not test. And then she took back. I said, stop the study group, focus on yourself for 30 days, and then now go take it. And that's what she did, and she passed right away, and she's gone on to a beautiful life and being a psychiatric nurse practitioner, right? So we have to, what kind of a defense mechanism would that be? If you rationalizing things, right? You just, oh yeah, you know, this is X, Y, and Z, but you would not take the board because you're almost scared of it, right? So it's a defense mechanism that sometimes we all use. Intellectualization, right? Great. That's what you said, Marie?
Yes, intellectualization, yes.
Yep, that's it, right? That's what she was doing. I was like, hey, you know, and she was doing this for 4 months, and she was doing studies group, and everybody in the study group was passing, and she would not take her test, right? So we have to look at those things too. Like, not everyone will be the same, right? We have people that come in with 3 weeks, took everything and done, gone. And we have people that are with us for a while. Wow, I love you guys, and I appreciate being with us for a long time. But if it's something that's holding you back, you know, you can always email me, and I get a lot of emails, and I try to get to each one of you guys, okay? But I cannot pronounce your name. Sikiki?
My name is Christiana. That's a mixture
Christian,
of
I'm gonna call you Psych NP. I'm gonna call you Psych NP, okay? If you don't mind me calling you that.
That's fine.
All right. See, Christiana Psych NP. We'll make that up, okay? Do you know, I'm going to put the link here for the course if you like to join us. Everything is recorded and ready for you. Yes. But you can also have the choice to attend the live course anytime you want. So, okay. But everything you need is available. You don't have to miss work. You don't have to even come to the live. It's just nice to see you guys and be able to talk and you know, and interact with the other. I'm gonna put you a code here that'll give you a very nice discount. So you attended today, you can have this discount. PMHNP.NP, so they'll give you a little bit of a discount there. But imagine this. I'm not selling you 5 different courses. I'm giving you all at one package, okay?
Okay.
So it's not expensive at all. So very worth the money for 6 months. What else? How else can there was another question there?
Can you go over some study techniques, like with
Sure.
the modules and the questions for somebody who works full time? How many questions a day should be done?
Perfect. Okay. How I would study. So are you working 12 hours, 8 hours, or what is your schedule like?
About 8 hours, maybe 10 hours outside. I'm already a FNP, but you know.
Right. So you are in danger. Okay. Why I would say that? Because you already have a mindset, concrete and established, right? So you are an FNP. How long you were an FNP for?
Since 2015.
Since 2015. So very established FNP, right? Yeah. Very technical and by the line. So that's why you are in danger, is because your mindset is concrete. It's like rationalize things and doing things by the book, and not a lot of it's like a true science, right? Like an ICU. It's like, oh, if I see this, I do this, right? So when it comes to psych, things are not as concrete, and they could be both ways, right? So just be careful. We had an FNP that is, you know, very difficult to change because you think like an FNP. So you have to put the hat away as you're taking these preparations, right? How would you study? I would say it's going to be painful, okay? This is how I would do it. I would wake up 2 hours early for the next 30 to 40 days. In 2 hours, I would make 1 hour of listening to the content, memorizing, and maybe 20 questions, 30 questions a day. Why early? Because starting is the most important thing of your day, yet is the least important. You are not going to study after a full day of working. It's gonna be hard. It's like going to the gym after you spent like 12 hours working. It's hard, right? So you make that like your first priority, and when you're done, your rest of your day is gonna be easy. I always say eat the frog first thing in the morning. So what does it mean? Well, do the worst thing first thing in the morning, so the rest of your day will be beautiful. There's nothing else to worry about, right? If you take care of that thing first thing in the morning, if you don't want to do 2 hours, do 1 hour. And you can divide that by 40 minutes of lecture and 20 minutes of 15 questions a day. If you do that 6 days a week, you golden. You don't need more than 1 hour a day consistently, maybe for 2 months. It'll be a little bit longer time now. Maybe 1 hour a day for 2 months. That should get you just whereabouts you need to switch your hat. Think of it like a student. Don't think like an FNP as you walk in there, okay? Think like of a student.
Well, I'm very disciplined, so I got through all the modules. I have everything printed out, all the notes. I got through it. The last minute review, your type. I have everything packaged. So now I'm going through the modules and the questions, and then go through module 1 again, go through module 2, and then the questions in module 2. Is that
Perfect? It is perfect the way you do it. So you do module 2,
yeah,
all the questions on module 2.
yeah.
Come back to module 3, all the questions on module 3. Now, the only thing I would say is that before you move into module 4, you have to have mastered the PDF for modules 1, 2, 3, 4. So the first one is easy, it's only one. Then you have 1 and 2. Now you have 1 and 2 and 3. So before you go to 4, you gotta be revising again 1, 2, and 3.
Yes, that's what I'm doing.
Yeah, I mean, if you do that way, I'll give you $1,000 if you don't pass the board. I mean, I promise you,
I'm gonna hold you to your word.
yeah. Go
I'm
ahead,
gonna pass.
but I'm gonna hold
pass
you.
first time.
You're gonna pass first time, okay?
I don't need that $1,000.
There you go. If you pass first time, I'll be as happy as you, okay?
That's right.
Kathleen,
right.
when are you going to take the test?
Well, I paid for the boards this week, so I'm still in school. I still have at least 3 more weeks.
You're already testing soon?
Well, I paid the ANCC for the test this week, but I still have to wait for the school to send the VOE.
Okay, so you don't have a date yet.
No.
Okay. So my heart almost, had a heart attack. Thinking like you tested this week. I'm like, no,
not yet.
Okay,
But I'm
okay.
getting there.
Good. It gets real when you get a date, okay? It gets really real. I'm like, oh my God, this is actually
freaking out.
Yeah.
Definitely you will pass, Kathleen. You have good knowledge.
Yes. It just be careful because a very concrete, very good knowledge, it can lead to not thinking like a Psych NP student, right? So sometimes too much is not good. So that's what I'm afraid of. But I love how you said that you're disciplined.
Yeah,
right?
I am.
Discipline is the number one thing that differentiates us from others, right? If you have the discipline, you become unstoppable. I don't care who you are or where you came from. If you want something that bad, you will get it. It's that easy, okay? Now, the hard part is the doing it, right? The hard part is the doing it. So getting up and going to the gym or getting up and doing that thing but as much as you do it, you end up loving it. It's just funny. I was like, I hate this thing that I have to do every day, but then you become good at it. And you're like, actually, I love it. I love this thing, right?
I actually enjoyed your videos. Everyone.
Thank you.
I was
Thank you. I
smiling
appreciate
as
that.
I did it. It was like, whoa, I didn't think of that,
Oh, okay.
Yeah,
So
I
love
enjoyed
it. I appreciate the feedback for sure. All right. So any other questions or anything else that I can help you guys with?
I have a couple questions, 2 questions.
Go ahead, Rebecca.
There are things I've hit on the question bank that stuck me, and I can't get a good logic behind it.
Okay.
This one says a patient on Lexapro reports worsening depression after starting treatment with interferon for a medical condition.
Perfect.
What is the most likely explanation?
All right. So
interferon directly causing depression because it's at beta bis. It causes depression, but that's not the right.
So perfect. So what else?
The other choices are allergic reaction to interferon.
No.
Interferon can act as an inhibitor, affecting the metabolism of other drugs like Lexapro and requiring dosage adjustments.
That is true. Yeah.
Okay. What else?
Lexapro losing its potency over time.
No. Well, it's true, but not probably the right. Yeah, not to that point right now. What else?
That was the 4 choices.
Okay,
I
so
interferon directly causing depression.
yeah.
But that's
So please send me the question because you are correct. But the other answer too is possibly correct, right? So
yeah,
the other answer was yes.
the one that
So
said interferon can act as an inhibitor. So
yeah,
that,
it is correct. Both are correct, right?
okay.
But you are correct as well, and you are correct based on what we teach. So this is a bad question because 2 answers are correct, right?
Okay.
But also highlights 1 point of what somebody just jump on and mention that the other question was correct, that the answer correct, right? What Rebecca is thinking is the right way because that medication, the intent of that question was to say, hey, this medication causes depression. So therefore, what I have to do, what the questions we will ask you in the test is not what caused what, is what will you do? And your answer for this question is to increase the Lexapro level or talk to the provider about interferon. Okay?
Yep.
So it will not ask you, most likely not ask you what the medication does, because nobody cares what the medication does. They care what you're gonna do about it. Okay? I mean, we care what the medication does because that's behind knowledge, but it's the applicable knowledge that they really care.
Right. And I had one more that was
Sure.
very switched around confusing like that
Please,
one.
Rebecca, please send me that question, okay?
I
Email.
will. Got a
Thank you.
picture of it. I'll put it in
Okay.
an email.
Thank
This one is a patient taking Tegretol, an inducer, also requires clarithromycin for an infection. Clarithromycin is an inhibitor. What potential action should be monitored closely?
Okay. So what can you tell me about this question without seeing the answers?
I
What
believe
the
you said
what
inducer beats inhibitor if they're on both.
That's right.
That's right. So go ahead. So we know that before looking at the answers, we know what we're possibly looking for, right? So what do we have as answers?
A, increased Tegretol levels due to combined induction and inhibition. No, it's the Tegretol that's the inducer.
Okay.
B, increased clarithromycin levels due to Tegretol-induced CYP3A enzyme. That's what I picked. C.
So hold on. So we
Yeah.
said that inhibitor will increase the inducer.
Now, I
right?
thought inducer beats inhibitors. It overrides.
again? Say it again.
I thought the inducer wins. If it's a head-to-head, I thought it was the inducer that wins. No?
So yes.
The
Backwards,
inhibitor
right?
wins?
Yeah, inhibitors win.
Oh, see, that
Okay.
was important to me that I get that straight in my head because I had
Yes.
backwards.
Okay, so here is the thing, right? When you say win, what does it mean? Anybody else can explain this question? What do you guys get out of the inducers and inhibitors when they're together?
The inducer takes over.
Okay, so what does it mean?
So if you have Tegretol and you have clarithromycin,
Okay,
it's gonna increase the dose of the medication,
which medication?
Tegretol.
Tagato.
So that means you might have to decrease the dose as a PMHNP.
You may have to decrease the dose.
Decrease the dose.
So this is was well we're explaining. Okay.
Right.
So Rebecca, do you understand that? This is your understanding. Because when we say win and lose, what does it mean? Right? This is exactly what it means, what she said.
But I don't think she said what you said. She said
No. When I say it
inducer
wins, right? I said the inhibitor wins, which means now is going to inhibit the inducer that will increase.
Yeah.
So it doesn't
by
mean
the
that it doesn't mean that the wean is that medication will be higher.
So just take it. The inducer wins. Wins in the
Sure.
sense of is going to increase the other medication.
Dr. Lopez, you're saying the inducer wins, but I think it's Kathleen talking. She's saying the inducer wins.
No,
Which
no, the inhibitor is going to increase. The inhibitor is going to increase the inducer.
That's it.
So you need to bring down the inducer.
Yes.
Adjust the dose of the Tegretol.
Yes. So when they say the inhibitor wins, really means that the inducer is increased.
Yes. That's how I understand it.
Yes.
I don't know.
Yes.
Yeah.
So it's
When
not that
I
the it's not that the inhibitor wins and then the dose is going to increase. So thinking of a wall is the inducer. So it creates a win by creating a wall, higher wall. So therefore the other medication can't pass and the other medication will increase. Right?
Right. But by the way, I think we're talking when we say wins, inhibitor wins,
Right.
that will be the foremost action. That will be the action that overrides the most active action. If you have an
Yeah.
inhibitor and an inducer, the inducer loses. The inhibitor will be the action that occurs. So the Tegretol will inhibit the clarithromycin, and you may have to
Do
adjust
what?
it.
Who? Adjust who?
Clarithromycin.
No.
No.
Oh,
Well,
no, I got backwards.
you could adjust the clarithromycin by decreasing it and therefore
Yeah.
increase the Torgatol, but it's actually the other way around here. Well, we
Other
want
way,
to, yeah, we want to increase the Torgatol because it was decreased. I mean, we want to, I'm sorry, decrease the Torgatol in this
I'm
case.
getting it. I just pushed the wrong button. I said it
Yeah.
back.
Okay.
Yeah,
All
I'm
right.
getting it.
Okay.
Okay.
All right. So
That's
we're good
awkward.
then, right?
Yeah.
Thank you guys for clarifying because that's actually a very important point that I actually keep dreaming about to fix it all the time. This win and lose. What does it mean? Like win inhibitors win. So what does it mean? Like really in practice, right? So we have to be more clear, more specific, so that we don't lose points on the details, right? The difference between a winner and a loser in a sport, like a competition sport, sometimes it's seconds, right? And that seconds is made up of months of work that they run. It can be very little, right? So we got to make sure that when we are confused on when things are said, they are not very clear, that we come up and say, hey, what do you mean by this, right? So we can get things clear up, all right?
Yep. And that
Thank
way,
you, I appreciate that.
it can just correct my thinking, my understanding, not my memory work, but my
Yeah,
understanding.
and sometimes I learn from you guys all the time. You know, sometimes people say something, oh, like, yeah, that's a better way of explaining. Let me write this down and I'll record and add that to the next class or so forth. So it's very important to always follow up.
You were telling the ladies that they should get up 2 hours early, you know, like if you wanted to go to the gym. Dr. Lopez, we have learned, don't ever go to the gym because your retina will detach. None of us.
Well, that was you know,
That's
probably
funny.
happened for other reasons. I know. I was thinking of that. Just like, see, I'm trying to do the good stuff, and then it happens to me that way. So,
Yeah.
all right, guys. Any other questions before I go lay
Nope.
down the prone position for the rest of the
so
day?
much.
All right, guys. So basically, we have this schedule out for the whole month of February. Any question, always email us because there are 20 types of different social media. Sometimes your question might be lingering there, and I'm eager to answer and be able to help. So email us is the first choice, or call us. Just be mindful of our time zone. late night for you guys is usually the time to call if you need to
I do
call.
want to join in your WhatsApp group.
Text your number to 240-389
240
340-289. I'm sorry, 240-389 8213. WhatsApp, and then that's for WhatsApp. You have to have the WhatsApp, and you text on the WhatsApp, and then we'll add you. Okay.
Thank you.
And Dr. Lopez, what's your email? I'm going to try to send these 2 pictures to you.
Please. I'm gonna write down here as a PMHNP. Oh, I can't see.
Email is already there in the chat box, sir.
Yeah, PMHNP at npexamcoach.com.
Okay, got it.
Hopefully I spelled correctly here. So, all right. Like, it's really hard to see with one eye.
Yeah.
Okay.
Thank you. Good night.
All right, guys. Good night. Have a
Thank
good
you,
one.
Dr.
Good to see you.
Lopez.
Thank you, guys.
Have a good night. Hope you feel better.
I sure will. See you guys next.
Thank you.
Thank you. See you guys next Friday night. Okay.
Good night. Yes.
All right.
Hey, good night.
Bye bye. Good night.